but there's still structural components which haven't been perfected yet for more long-term durability, which we're interested in. But they're great early steps towards, valve replacement.
Now, I'm just curious, if I understand correctly, you're saying there's a host compartment, a host involvement, that once you put it in the body actually helps it become more like a valve?
Correct. It's a combination of circulating cells, but also a lot of the cues come from the matrix itself, and it goes back just like the amputation of the finger. The matrix actually causes homing of certain different types of cells. It has certain cues in there that when the blood comes in contact with it, certain type of cells actually adhere to it and cause differentiation. So if you just put inert polyurethane valve in there, you won't get cellularization.
I see.
And that's the exciting thing. That's the exciting thing about this whole field. And admittedly, we've got a long ways to go yet to really fully understand how this works. But the promise, of course, is that these cells are, as you said, Tom, very responsive to their environment, to their niche, to where they are. And as I heard Arnie Kaplan say a couple of weeks ago, many of these cells, like the mesenchymal stem cell, which you referred to, can act as your local drugstore in the sense that they respond and thereby secrete and recruit that which is needed and is demanded by the local environment they find themselves in.
Well, see,
and that's why it would be very difficult to replicate the potential function of these cells in situ. In other words, where they are by a single drug or a single chemical which has a single mechanism of action, because it's such a complex biological matrix responsive mechanism.
This brings a very interesting point, I guess. In my company, what we've always been trying to focus on is seeing our cells as an adaptive anti-inflammatory, or like you said, a cellular drugstore that secretes things. But it's a very important distinction between what we are trying to do in a certain way and what our colleagues, if you will, in the embryonic stem cell field and some of the other fields are trying to do, which is we as a company never went down this road of making the artificial organ. And the reason for that was because we have a cell population. We know the cells make huge amounts of growth factors every month inside the woman's endometrium, and we're just trying to use these cells to deliver these biological factors. This field that both of you guys have started talking about is really, I think, the next generation and the very exciting one of being able to make an organ. So along those lines, there was this paper, I forgot the name, it was a lady, I think her last name was Taylor, where she took the extracellular matrix of a heart, if I remember correctly, and she put some stem cell composition, and then it was
Doris Taylor.
Doris Taylor. And what's the story with that? I just vaguely remember it. I mean, she was your colleague, wasn't she, back at Pitt?
Well, so that's interesting, because the same lab that came up with the matrix for the finger was working on this project, and she actually was able to see that on the larger hearts it was much more difficult to do. And it ended up that she figured out how to basically use a detergent-like substance on a rat heart, which is about the size of a dime, completely decellularize it just like you would for the valve, and recellularize it with cardiac myocytes. Again, you still needed bone marrow and some smooth muscle cells, and you'd actually pace the heart. And more recently, Laura Nicholson in the Northeast also has been able to do the same process to repopulate the cells of a lung. So at a more microscopic level, so basically at the rat or mouse level, you can now decellularize and recellularize organs. It's a very interesting concept at the animal level, mechanistic, and for a lot of different things. But when you start thinking about, can we ever do this in patients, the interesting concept becomes, by the time a patient would need a heart transplant, if we could take their old heart out, decellularize it and recellularize it, the issue still becomes their matrix. Programs, you're taking healthy organs and doing the decellularization, recellularization.
Now,
and that's something that's going to be very difficult as you scale up.
Now, I should know this as an immunologist by training, but I don't. How immunogenic is the extracellular matrix? I mean, if I was to use a dead person's heart but recellularize it with my own cells, how immunogenic? Would it be rejected? Or the ECM, is it very immunogenic? Or?
That's a great question, I don't think Topsy. No one knows that. We know that small sheets...
Mm-hmm.
Oh, go ahead.
Go ahead. No, go ahead, Amit. You're on it.
So small sheets of this matrix we use for repairing hernias and other things currently in patients, but doing an entire organ level, we don't know the immunogenicity yet.
I see. But
I think the other exciting sorry, go ahead, Tom. I'm going a little bit off track. So.
I was going to say, I mean, immunogenicity, the main component obviously is the MHC1 and MHC2. So perhaps it wouldn't even be that immunogenic. But so what is the limiting factor? I still don't really understand it. I mean, conceptually, if I had heart failure and I had enough money, I could, with the right bioengineering lab, the pieces exist today. It's just a cost issue, right?
Correct. It's a scalability of going back to the angiogenesis thing, that thin layers of tissue you can repopulate to create organs. But once you start looking at hearts where you're getting multiple millimeters, 5 to 10 millimeter thickness, it becomes a vascularity issue that you can use the cell sheet type of techniques of layering one layer of cell after another. But if you don't have enough blood supply, then you're still going to have the same problem. And that's been one of our main concerns right now, is how do we scale this up to human-sized organs where the thickness of the tissue becomes a significant component. So it's the whole 3D component. Mm-hmm. The 2D...
But I think it's... I think it's very promising in the sense that the decellularized model already has the vascular structure built in it, right? It doesn't denigrate that vascular structure, so it brings us at least part way to having an embedded vascularized structure, but you still have to vascularize the tissue that you're building itself. Is that the issue, Amit?
That's correct, and I think if we can get donor hearts that are not used for transplant, and we can get those for many reasons, that there are still hearts that are rejected. If we can start using those as our early models of decellularization, recellularization, then we may be able to get as close to an autologous type transplant, and that may be the first realistic model of organs, especially large organs, where this concept can be scaled up. So you may not have a true tissue engineered organ, but it may be very close to make it less immunogenic.
Very, very interesting. Very interesting.
So the other cool application of this, Tom, of course, is the other side. I like to refer to it as of regenerative medicine, and that is the use of these cellular structures that we're building, not directly as therapeutics themselves, but in the discovery of other potential therapeutics. So, for instance, what we have here in this heart model, for instance, is the potential to build a live, functioning 3D model of a heart that you could imagine, be very nice, be a very nice model for toxicity testing for drugs, for instance.
Yeah.
This whole 3D modeling application is the pot at the end of the rainbow for many, moving from two-dimensional testing in 96 well plates, for instance, to moving to 3D models where you can actually test drugs a lot of toxicity to hearts and livers is a big problem in the drug world. And if you could actually have a functioning, beating 3D heart in the lab that you could test drugs on, that would be very cool.
This reminds me, our colleague, Dr. Eduardo Mancilla from Argentina, at the last ASH meeting, the hematology meeting, we were sitting down talking about this area, which, to be quite frank, I know very little about the extracellular matrix, using it as a scaffold for making organs. And he was telling me that he actually was doing some preliminary work on brain, doing this with brain. Have you guys heard of anybody entering that field?
Wow, no.
Yeah, I haven't heard about the brain. I know that he's using it to actually scale up burns, to actually think about using a artificial skin-like product, so where you have matrix and it also decreases the scarring and wound contractures, which is a significant issue with burn patients where skin grafts really fail. But it's incredible if he's figured out how to use it to grow sheets of neurons or oligodendrocytes or something to actually put it into brain. That would be much more challenging than anything we do in cardiovascular disease.
It would be going into some very bizarre areas. Now let's just take the conversation, I guess, a little bit back on what the producers asked me to talk about, I guess, which is this whole concept of regenerative medicine. So, we just talked about some very neat applications, building de novo organs. I mean, this is beautiful. But my question is, what did you guys think about? Was there a particular event in your mind where you would start thinking, that made you think historically about this paradigm shift into regenerative medicine? I mean, I guess my little kumbaya moment, if you will, was when I started seeing the work with the bone marrow transplants. When females would be receiving male bone marrow transplant, then the females would die of other things. They would do sections of the female's different organs, and then they saw Y chromosome, male-derived cardiomyocytes in the female, or male-derived liver cells in the female. That's when I think was, at least in my mind, this whole conceptual shift and that regeneration. Probably that, and there's a couple other examples which I'll touch upon, but are there any examples in your mind where you had that moment where you were like, wow, there really could be this regeneration of the body. It's not just in the salamander.
Well, Tom, it's interesting you mentioned that as your kumbaya moment, because that's a very interesting yet controversial concept of the male-female mismatch and seeing male cells in different female organs. And the caveat to that, which we have seen in transplantation, is many females, if they have had male children, there is still some loss of those male cells that cross the placental barrier and can go systemic. And that's been one of the concerns when everyone has brought up the whole concept, because we've seen this also when we take male hearts and put them into female recipients, and you'll see cells that go across both sides to say, are these cells in other organs? And that's always been the concern, is we have not been able to document, or any other group that we know of, where they could prove that that female recipient never had any male children that may have embolized these cells throughout the body. But that's one of the things when I first saw it too, that this engraftment thing and regrowing looked incredible until people introduced to me, they're like, hey, this is one of the key concerns we have, that as great as this sounds, this is where the science just doesn't hold up yet, is you could still have systemic embolization of maternal fetal cells.
This is very interesting, because, and maybe you guys can tell you, one of the things I find about this field in general is that there's a lot of haters. There's a lot of haters. People,